So in celebration of Breastfeeding Awareness Month, I'd like to welcome Dr. Diane Spatz, who's going to share her expertise for mothers and families around breastfeeding. Dr. Spatz is Professor of Perinatal Nursing and Nutrition at the University of Pennsylvania School of Nursing, where she shares a joint appointment as nurse researcher and director of the lactation program at the Children's Hospital of Philadelphia. Dr. Spatz is an active researcher, clinician, and educator who is internationally recognized for her work surrounding the use of human milk and breastfeeding, particularly in vulnerable populations. Could you just tell us, starting really at the clinical level, why breastfeeding is so beneficial?
Sure. Breastfeeding has so many benefits, both for the mother as well as the infant. I'll start with the mother first. For the mother, it protects her from all kinds of reproductive cancers, breast cancer, ovarian cancer, endometrial cancer, because it's the normal life cycle of the breast for a woman to breastfeed. It helps the mother to have strong bones when she is in her elderly years. It will help the mother to lose some of her weight that she has gained while she was pregnant, because breastfeeding burns calories, so it helps the mother burn those fat stores that are laid down during pregnancy. And in particular, for a mother of a preterm baby or a baby in the neonatal intensive care unit, providing milk, pumping for her baby is the one thing that only she can do. And her milk is like a medicine for her child. So for mothers who have sick babies in neonatal intensive care, their role is of critical importance, and many women say it's a very empowering experience to provide milk for their baby, as well as helping them to be connected to their child. So the mother has both short-term and long-term health benefits, and also it's good for her mental well-being. For the infants who are breastfed have so many advantages. They are less likely to get sick, and if they do get sick, they have less severity of illness. So things like a reduction in the ear infection rate, a reduction in respiratory illness, a reduction in GI upset or feed intolerance. So human milk is much easier for the baby to digest. Every day that a mother provides milk for her baby or breastfeeds her baby, she is giving that baby a whole host of immune properties. So antibodies and immunoglobulins, proteins, substances that will never ever be able to be found in any infant formula. So that milk is helping to build the baby's immune system. So not only is it good to protect the baby from all kinds of infectious processes, it's also better on the baby's digestive system. So in particular, for babies who are in the neonatal intensive care unit, they often have to start their life on IV nutrition. And if we can feed the babies human milk only, we can reduce the number of days that the babies need IV nutrition, because human milk is much better for the baby's digestive system, and it's easier for that baby to use that milk and to digest it so that we can get them off of IV fluids quicker. The other really significant thing about human milk is its effect on the baby's brain. And so we have research that shows that breastfeeding makes your baby smarter. So there are higher scores on tests of IQ, and there are also higher scores on developmental outcomes when you breastfeed your baby. In fact, recent research where they've done what's called MRI, or magnetic resonance imaging, a scan of the brain, they've been able to show that babies who are exclusively breastfed have about 20% more white matter in their brain. And white matter is the part that is important for neuroregulation and neurocommunication. So human milk doesn't just protect the baby from disease and illness, but is also going to help them achieve the best possible health and developmental outcomes they can.
Wow. Can you tell us a little bit about the challenges that some moms do face in breastfeeding as a NICU mother?
Sure. So I think one of the worries I always have is just when women have a lack of support or a lack of education. I would love to tell you that every hospital makes the provision of human milk a priority and makes helping moms pump a priority, but unfortunately that is not the case. Recent research that was done by one of my PhD students found that only about half of neonatal intensive care units actually employed lactation consultants, and that a very startling few number of nurses were providing breastfeeding support. So I think one of the most important things for a mother to do is to really empower herself. She needs to do her research, and she needs to get well informed so that if she has a preterm baby or a baby that's in NICU for another reason, she needs to be her own best advocate. So one of the first things is helping that mom make an informed decision to start pumping. And then for the mom, it's really important that she is pumping early and often with a high quality pump. So pump access can also be a challenge for moms because some mothers don't have access to breast pump, or their insurance won't cover the cost of a hospital grade breast pump. So a mother may have to negotiate that challenge of trying to find a high quality pump so that she can express milk. Often you'll read or hear in the literature that mothers who have preterm babies cannot make enough milk for their babies, but that is not a research-based fact. The first 2 weeks of a mom's experience after delivering baby are critical. So for the first 2 weeks after delivery, the mother's only job should be to eat, sleep, and pump for her baby. Eat, sleep, and pump for her baby, and establish her milk supply. The next challenge, I would say, is once milk supply is established, is getting that baby to transition from tube feeds of human milk, because most babies in the NICU will start off their life getting tube-fed milk, and then we want to get them to be able to breastfeed at the breast. And so that process of transitioning to direct breastfeeding is reported by mothers to be challenging, and also, again, sometimes with staff if they're not well informed of how to do that process. So again, the mother needs to be her own advocate. So the first step that will facilitate the direct breastfeeding is doing oral care with human milk. So the mom coating the inside of her baby's mouth with the milk while the baby is still not able to eat or just getting tube fed. And then the next step would be making sure she's holding her baby skin to skin every day. And then finally working on the actual direct breastfeeding at the breast. And so that can be a challenging time, and the most important message for the mother is to be patient.
So informed decision, education, empowerment, lactation consultants, and support within the unit are critical. When we're talking about the challenges also, if mom can't breastfeed, what are some of her options?
Absolutely. So in our institution, we really view human milk as a medical intervention. And so we, if a mother for some reason couldn't provide her own milk, she had breast reduction surgery or she has abnormal breast tissue development, which is very rare. It's only about 2% of the population. We have donor milk available. And so in a neonatal intensive care unit, really, it's quite risky to put formula into a baby's belly. So if mother's own milk was not available, then donor milk would be the ideal choice. Now, donor milk is not a replacement to mom's own milk. It's a bridge. It's not going to be as good for the baby as her own milk because the milk has been heat treated, so some of the beneficial components of the milk are destroyed. However, donor milk is a much better alternative than putting formula in the baby's belly.
And can you tell us about the additional nutritional challenges that premature infants face?
So when a baby is born very low birth weight in particular, so babies who are born less than 1,500 grams, because their size is so small, it means they also have a very small stomach capacity. So a normal, healthy breastfed baby, a healthy term baby who's breastfeeding, on average consumes about 750 to 800 milliliters of milk a day. With a little tiny baby, there is no way that you could put that volume of milk into a tiny baby. And so we have to give the baby small volumes of feed. And because of that, it's very challenging to get adequate protein, calcium, and phosphorus, particularly in the smallest babies who are less than 1,500 grams. And so what clinicians have to do is they have to add fortifiers to the milk. So they add a substance to the milk to increase the protein, calcium, and phosphorus, as well as the caloric density. So many moms get very frustrated by this because they feel like they are getting mixed messages, that they're being told that pumping is so good and their milk is so good, but then they're being told that their milk is inadequate, and so providers want to add substance to it. But it's really kind of understanding how human milk works and the fact that it's not that the milk is inadequate, but it's that we can't put a large enough volume into a very little baby's belly. So this is the reason that we have to add fortifiers to the milk.
What is the difference between human milk-based fortifiers and human milk fortifiers?
So until recent years, the only type of human milk fortifiers that were available were made from bovine products. They were made from cow's milk. So a traditional human milk fortifier that is either powdered or liquid in nature is made from bovine or cow product. And so with that product, you will perhaps see feed intolerance because you're introducing a cow's milk protein into the baby's stomach, which can cause damage to the gut wall. There is a human milk fortifier made from human milk that is made by Prolacta, and that product, what that does is it adds the protein, the calcium, and the phosphorus, but it is only a human milk product. So that product has been associated with a reduction in necrotizing enterocolitis, so that's a disease of the bowel. Remember earlier I talked about the fact that human milk is easier for the baby to digest, and human milk also matures the baby's gut wall. So by keeping a baby on a 100% human milk diet, you reduce the risk of necrotizing enterocolitis, which is a very scary disease of the bowel. And in addition, by keeping the babies on a human milk diet only, you reduce the number of days that the babies need that IV nutrition. So that means if we can get them off of IV nutrition quicker, that's much safer for the baby. And it means we can get them on full feeds, complete feeding of mom's own milk through their belly.
Fantastic. And can those fortifiers also be added to human donor milk?
Absolutely. So with donor milk, one of the things that we know about it is that, as I mentioned earlier, it's not a replacement to mom's own milk. And donor milk, we know, sometimes does not grow a baby as quickly. The babies will have slower growth. And so we can add the human milk fortifier, the Prolacta Plus, right to donor milk to increase the calories as well as the protein, calcium, and phosphorus.
We've heard a lot in the news lately about dangers of sharing donor milk. Can you talk to us a little bit about that and help the public to understand a little bit about the safety and the quality and the importance of that for moms who either can't breastfeed or choose not to?
Sure. So when we think about understanding the differences between mom's own milk and donor milk and what some may call informal milk sharing or private arrangement milk sharing, the thing that one has to remember is when we're talking about a mom providing milk to her baby, her and her baby are always in sync. So she's going to be the ideal person to provide the ideal nutrition for her child. Now, if for some reason the mother was not able to make milk for her baby, when you think about the difference between donor milk and informally shared milk, donor milk, the mothers have gone through a very thorough screening process. It's more thorough than giving blood. So the mothers have to do a health history. They have to provide a health history on their baby. They have to undergo laboratory testing of their blood to make sure that they are free of disease. And the milk also is checked, and it's also pasteurized. So with pasteurization, you are destroying any potential germs that might be in the milk. You actually check the milk after it's been pasteurized to ensure that nothing is growing in the milk. So with informal milk sharing, when mothers don't go through an improved milk donation process, that means there could be harmful bacteria or germs in that milk. And so that is the danger of when moms are casually or informally milk sharing. The reality is that some women choose to do this, mostly in the community setting, because they can't get access to donor milk. Right now in the United States, only about 40% of NICUs even use donor milk. And if every NICU used donor milk, as per the American Academy of Pediatrics recommendations, we would have a shortfall of donor milk. And that's why you will sometimes hear of people informally milk sharing. So, I think it's really important for a family to understand what the differences are and understand the years and years and years of research behind donor milk being both a safe and efficacious product for feeding babies.
Very good. Empowering parents with practical advice. You see this every day. How would you advise them to talk to their nurse practitioner or their doctor about donor milk for their child?
So first and foremost, I want to make sure that we're clear that donor milk is not a replacement to mom's own milk. So the first thing is I would want to make sure that we empower the mothers to be able to provide own milk for their baby. If they were not able to provide 100% of their own milk for their baby, I would encourage the mother to know the facts, do her research, go to the provider, whether it be a physician or nurse practitioner, and speak to them about the fact that they would like to have donor milk for their child. One of the things that we do for our mothers who deliver with us in our Center for Fetal Diagnosis and Treatment is we actually bring up the topic of donor milk before they even deliver. So we want them to know that their own milk is the best, but if for any reason they run into a problem, we have donor milk as a bridge. So if I was advising a family who was pregnant, I would ask them to do the research on the hospital that they're delivering at. Make sure that that hospital has lactation support available. Make sure that that hospital has donor milk available if the need would arise.
Anything else that you'd like to share with mothers and families?
I think in closing, for the mothers and their families, I think that it's so important for the mothers to understand that they need to arm themselves with information. They need to do their homework. They need to be well informed. They need to be their own advocates. Once they deliver, they need to pump early, ideally within an hour of the baby being born. They want to pump often. And so our mantra at Children's Hospital Philadelphia is pump early and pump often. We want the mother to ideally achieve a milk supply of somewhere in the 750 to 1,000 milliliter mark a day, which is feasible when moms are pumping early. The family has to support her. We actually give our family members a job list of 10 things that they need to do to support the mom that first 2 weeks after delivery, because a mom's job is just to eat, sleep, and pump. That's her only job if she has a baby in the NICU. And it needs to be very clear for the family that this is a team effort. The mom can't do it by herself.
Absolutely. Well, thank you very much for your expertise today, and I'm sure that as we celebrate Breastfeeding Awareness Month, this has been extremely helpful to parents, especially those with vulnerable children in the NICU.